Well, hello, this is Eric Shi. I'm a podiatrist practicing with Sutter Health in Oakland and Castro Valley, California. I just want to thank Dr. Nyagu and the rest of the scientific chair for giving me the opportunity to present this morning in the wound care section of this conference. This morning, the title, the task I was given was to talk about, the title is Healed, Determining the Level of Amputation and Search for a Predictor of Healing. I don't have any disclosures. So, yeah, this is a very common scenario just in my training and even now in practice that kind of we go through. And so typically a patient comes in with infection or with or without gangrene requiring amputation. And if they do have gangrene or some sort of vascular compromise, we would get the vascular consult and the vascular surgeon will see the patient. And at that point, they would either recommend revascularization, in which normally they say, great, we have inline flow, you're ready to amputate. Or they'll say, oh, we don't need to revascularize the patient, go ahead and amputate and see what happens is usually what they say. And so usually, at that point, we go ahead and perform the amputation, whatever level they recommend or is needed. And a lot of times, unfortunately, they get dehiscence and the surgical site doesn't heal. We then perform local wound care, and that fails. They get infected again, and they end up needing a more proximal amputation. And throughout my training, especially as a resident, you're kind of at the front lines dealing with these patients. You're rounding on them. You're doing the wound care, and then it gets frustrating because you do the amputation, you see what these patients have to go through, and then it just becomes a point where you wish you had a crystal ball where you could predict this is what's going to happen. This is what the patient's going to need, a more definitive level of amputation, and let's just do one amputation, get over with, so the patient can move on with their life, have a good outcome, good success. And that's what I really wish we had over the years, and hopefully this lecture provides some insight into that. So this is kind of usually how it presents. Basically there's so many directions a patient can come in with just a wound or an ulcer, with or without gangrene. They get the revasc or bypass, either endovascular or open. They oftentimes can dehisce. You end up doing local wound care. They may or may not heal, or they may end up with a more proximal amputation. Just kind of summarizing what I talked about earlier. So after doing my own research and doing all the literature review for this, when preparing for this presentation, these are kind of the six, I guess, qualities or factors that I think I want to focus more on considering when determining level of amputation. Obviously, you want to, based on the extent of infection, you want to be able to remove all the infected tissue. You want to consider their functional status, the rehabilitation potential, their age and comorbidities, their vascular status, obviously, whatever they're able to heal, their quality of life, and obviously the patient's preference. This is their body, and they have a right to help make the decision in addition to your recommendations as a doctor. So when I think about amputation goals, it can be summarized into three main things: infection control. So you want to get rid of infection. That's kind of the primary goal of any infection control surgery is to remove all infected tissue. You want to optimize their healing potential. So you want to give them a limb that has a low chance of reulcerating. And finally, you want to give them a functional limb, a limb that they can actually use. And I think the key word here is rapidly return to mobility and function. And so, you don't want to give them a limb that where it won't work or reulcerate. You want to give them something that they can use. Amputation failure, obviously, is what we want to avoid. The definition of that, it can be described as an amputation that never heals or reulcerates. It could really result in a poor quality of life for the patient and a really high cost for the healthcare system, as well as time for the patient. Really, it's going to these doctor follow-up visits, rehospitalizations, the need for repeat debridements. And so we really want to try to avoid this in patients who already have enough going on in their lives with all the other medical issues going on, and as well as having to deal with returning to hospital for repeat infections and breakdown of their amputation site. This was a study out of Journal of Vascular Surgery and out of Johns Hopkins, and it kind of looked more at the financial side of things, and kind of over the past few years and past decade or so, the more greater focus on costs, and especially with the Affordable Care Act, and really a lot of financial pressure in terms of trying to reduce cost of healthcare. And they kind of found that they looked at 762 patients with either toe or TMA amputation. Found a 14% readmission rate out of these patients, and of those 14%, over half, 64%, lost their limb. And basically they're saying, obviously it's a pretty high readmission rate, and I think they were just stressing the importance of really keeping in mind the cost side of things and how much stress and financial burden this puts on the healthcare system. And they found that in this study, there was almost a pressure for surgeons to do a more definitive amputation to avoid a financial penalty, which was often the case in some of these hospitals where if they found you had a high readmission rate, the doctors actually get dinged with a financial penalty. So I think just something to think about in terms of when making our decision for doing the right thing for the patient. And not only, a cost is one side of things, but really at the end of the day, it's doing the right thing for the patient, what would give them the best outcome, really. This is a study done by the International Working Group Diabetic Foot in 2019, looking at basically all the classification systems out there for diabetic foot. So, we're familiar with a couple of these, and basically they listed each classification system and they described the use of it. And I remember, training in residency and fellowship, a lot of things would say we had to memorize all these classification systems in school, and a lot of them were very obscure and not really helpful. And at the end of the day, we really find that classification system is only useful if it dictates treatment or outcome. And so a lot of these studies, a lot of these classifications are useful in the sense, like the SINBAG classification provides communication amongst health professionals in terms of classifying the diabetic foot. The the Infectious Disease Society provides a good classification to help kind of aid in decision making, but there's no classification actually to predict an outcome of an individual ulcer. You do have the Wi-Fi classification, which comes close, but that one talks more about the more of the risk and more so assessing the benefit of perfusion after revascularization. So they basically found that they were unable to recommend any of the classification systems to provide a prognosis to guide management or treatment, which is kind of the key or most important thing that you would want from a classification system, such as the Gustilo-Anderson for open fractures. We all know that one well because it provides treatment management recommendations. And so this group basically recommended that we should direct our focus into coming up with a classification system to determine the prognosis of an individual with a diabetic foot ulcer and their prognosis of their limb. So this is just a slide on a summary on the Wi-Fi classification system. I just wanted to summarize it briefly, just because I think it really is an attempt to come as close as we can to really help predict an outcome for these limb salvage patients. And so just to summarize it real quickly, it looks at three key factors: wound, ischemia, and foot infection. And it uses these three criteria to basically come up with a score to determine the risk of limb loss at 1 year, as well as whether or not revascularization would benefit the patient. And they kind of stage it based on very low to high risk of limb loss at 1 year. And it's kind of the best classification out there currently that attempts to set patient goals and expectations. However, that being said, it kind of doesn't. It's not super clear. At the end of the day, the way the classification comes down to these kind of recommendations from very low risk to high risk, and sometimes that's kind of unclear. And how do you communicate that to a patient? If you say, oh, you're after doing all the scoring system, you're at moderate risk or high risk, for a patient, that it's hard to say, it doesn't really dictate treatment at that point. Do you still salvage a limb? Does that mean you give up on them if they're moderate risk or high risk? And I think, it doesn't provide any clear scientific, statistics in terms of actually giving the patient a percentage, what may or may not work. But nonetheless, I think it's a good starting point in terms of at least giving the patient some sort of expectation. Hey, you have a high risk of losing your limb in a year, so you may consider doing a more proximal amputation. So, I do applaud the authors for really implementing this. So when determining level of amputation, you really obviously want to assess vascular status, and there's a slew of different methods of obtaining that. We're all familiar with ABI, TBIs. However, we know the weakness with that due to non-compressible vessels. There's the Doppler thermography, skin perfusion pressures, TCPO2s, and a lot of these newer ones, such as this kind of fluorescence angiography. That being said, just to remember, these aren't the only predictors of wound healing. However, these are good methods to assess vascular status, which is key. So TCPO2, transcutaneous oximetry, basically is a way to measure oxygen in the tissue using electrodes. You can run the risk of skewed readings because of edema and calluses, so just keep that in mind. However, it is a better prognostic value than ABIs to predict healing, which is why they use it actually in the Wi-Fi scoring system. This is a study basically looking at TCPO2 and found that it's kind of only useful as a cutoff measurement. So it's more of, doesn't really provide like a risk stratification per se, but it's more of saying, oh, if you're at this level, less than 40 milligrams of mercury, you have an increased risk of healing. So, above that, you know that you're going to be okay, and less than that, it's going to be increased risk. So obviously, the lower the number, you have increased risk of complications. This was a study basically looking at all the different types of methods to assess for vascular status, and basically found that more or less these studies all provide more of a threshold, in the sense that that if it's higher than a certain number of level, such as for TCPO2 greater than 25 milligrams of mercury, you know that they have a higher chance of healing. But if it's lower than a certain level, then you know that they're at an increased risk for complications. So I think these studies serve more so as a guideline and more of threshold markers, in terms of if you have a high value, they're going to do great, but if you have a very low value, they're going to do poorly. But anything in between, it's kind of it's kind of unclear. I think it can be more in the gray area, and I think that's where a lot of the guessing game comes in, especially when we're doing these amputations, when they kind of have somewhat of a they don't have terrible flow, but they don't have great flow, and you're kind of in the middle, then you're still kind of stuck. You don't really have a clear direction, I guess a clear predictor of which direction to go. So that's kind of what these studies found. Again, this is another study looking at different measurement methods, and they found that skin perfusion pressures, the TCPO2 toe pressures are more useful than ankle pressures ABI, just mostly because you're focusing more on the microvascular small vessels in the foot. Fluorescent angiography is something that I was kind of excited. I was first exposed to it when I was a student at the VA Palo Alto, and it seemed almost too good to be true. You put this camera, you put some dye in the patient, you put this camera on the foot, and it basically shows what's dark is not going to heal, and what's lighting up is going to heal. And so just doing a more recent literature review on this in 2010, Zimmerman and colleagues, they found decent success in 9 stumps and found that they were able to produce future necrosis. Yang and colleagues did it on 17 amputations. However, 35% of those required revision. 83% of those needing revision needed a more proximal level of amputation. And basically, the issue that they found in their study was that when using this device, you have these values called the absolute pressure value, which is the intensity of a fluorescent signal is almost subjective, and it's not super clear cut. So they found that just because part of the toe lights up a little bit, it wasn't always predictive. And this final study in 2016 basically argued that the system, the fluorescent angiography, kind of only looks at the superficial capillary system and not necessarily deep tissue perfusion, which is what's really needed to heal an amputation site. So at the end of the day, and even in my own experience throughout training, just kind of this is one of those that I think is a good idea and good concept, but still isn't the key to really predicting what may or may not heal. So unfortunately, I think more work has to be done, especially maybe even studies with a greater population. This is a study in 2019, basically, interestingly, looking at patients after they went endovascular intervention. And I think the point that they were making was that 57% of patients after revascularization, or what the surgeon deemed as a successful revascularization, actually had a decrease in perfusion, which is odd and shocking. And they kind of attributed that to basically the fact that even after you have a quote successful angioplasty, the patient may still have a component of microvascular disease, or may throw microemboli or vasospasm to where they still don't have, I guess, perfect flow or ideal flow and what you would expect after what they saw after what they deemed a successful angioplasty. I think basically saying that not all, I guess angioplasty and what they were doing wasn't always 100% true to what the vascular surgeon was finding at the time of the real-time imaging in the lab. And so just something to keep in mind. I think, when the vascular surgeon, obviously they're trying their best to revascularize these patients, and when they come to you and say, oh yeah, they have great flow, and the patient doesn't heal, there's always a component of, microvascular disease, I think, that's kind of unknown or isn't always, I guess, a guarantee, when just because the vascular surgeon says they have good flow doesn't mean the patient's going to heal. So I think that was my main point that I got out of the study. This is just another study looking at fluorescence angiography, and basically they found that it was a good adjunct, but it was inconclusive and lack of standardization, again, specifically in interpreting the data. So again, the way this method works is it generates these numbers in terms of the intensity as well as the time to perfusion, and a lot of it was hard to interpret and didn't always correlate with what would or wouldn't heal. I found this nice study it just came out recently, 2019. It's a 163-page document put out by the basically the Global Vascular and Endovascular Society. Basically, it's the top dogs in the world on vascular surgery coming up with their recommendations on basically chronic limb threatening ischemia. In regards to, I guess, finding a method of measuring a perfusion, they concluded that there's no single definitive method of evaluating tissue perfusion that can accurately predict the wound healing potential or amputation or failure at the amputation. Basically, they're saying that all these methods of measuring blood flow or perfusion are helpful, but none of them accurately predict the optimal level of amputation. So I think that the search is still going for a good predictor. This is just a useful flow chart in their study that I just want to throw in here, just kind of looking at the way they triage these patients. And mostly, first off, when they come in, you want to get their ABIs, and if they're abnormal, then ordering more advanced imaging or more advanced tissue perfusion measurements, whether it's toe pressure or Doppler waveforms, and then staging them. Levels of amputation we're all familiar with, different, more distal versus more proximal. Some of us may perform all of these, or some of us may not, depending on your training. I know in my training, show-par amputations and partial calcanectomies or even calcanectomies were rarely done, just because we knew that they had poor outcomes. But nonetheless, this is just here for completion's sake. So limb salvage in general, you really is really key. Obviously, you want to return patients to ambulatory status. However, it's kind of unclear how you determine the ideal candidate. A lot of factors come into play. You have the age of the patient, their conditioning, what their baseline ambulatory status was, their psychosocial factors, as well as how compliant they are. And I think these are all factors you want to think about when you're determining who you want to salvage a limb on. And it's a team effort, and the patient has to be involved, family has to be involved, and it's not just as easy as it's not just as easy as doing it on everyone. I think you really have to take the whole picture into mind. This is a study out of JFAS in 2016 that we all know that after any major amputation, you really have an increased risk of more 5-year mortality, right? And that's something we're all really familiar with, and which is the importance of salvaging as many limbs as we can to keep these patients ambulatory. Limb salvage in general can be challenging. We deal with these sick patients with peripheral arterial disease, as well as diabetes, which are the biggest risk factors for limb loss when salvaging any limb. These patients are high risks, and up to 24% need a more proximal amputation. And I hope that we can, over the next few years and decades, we can bring that number down to where we're not needing to whittle away at the foot. And however, we do know that limb salvage is critical. Like I said earlier, the high 5-year mortality rate. We want to keep them walking and keep them on moving. I just found these next few slides are just studies looking at particular outcomes after certain levels of amputation. This one's by Rukas and colleagues in 2013, which actually found a really high repeat amputation for partial first rays. They found that a 70% re-ulceration rate, as well as a 42% of patients who needed more proximal repeat amputation within 2 years after partial first ray amputation. Their conclusion was that basically the partial first ray amputation is not reliable. You shouldn't do it. It's not a durable level of amputation. I think in my experience, partial first ray, obviously is not ideal, but patients, it's better than jumping straight to TMA, in my opinion. And so I think my takeaway was that if you do partial first ray, obviously, like anyone do amputation, you want to keep a close eye on them afterwards and monitor them and make sure they don't break down further. Transmetatarsal amputations, we're all familiar with. It's kind of, in my hands, been a love-hate relationship. Oftentimes you have a lot of trouble healing these. Basically, these colleagues in 2011 out of JAMA Surgery, Landry et al. Found a 53% healing rate and a 35% rate where they went on to below-knee amputation. And they found, unfortunately, nothing was able to predict whether or not they were able to heal their amputations. Their conclusions were that the TMA should be offered to patients who are going to be able to ambulate afterwards, that that are going to be able to ambulate. But if you know that they're going to be a poor rehab prospect, they're bedbound or they're sick, you may consider more proximal amputation because the TMA, can be challenging to heal, and it's a lot for the patient to go through to heal it, and maybe too much stress on the body. This is a study out of JFAST looking at TMAs as well, and basically found a similar rate of nearly a third of TMAs will result in below knee or above knee amputation. And they found also that the ABI didn't differ between those who failed versus those who healed, and kind of unclear in that area. However, they did find, as in many of these studies in limb salvage, that renal disease and elevated hemoglobin A1C are risk factors. So again, they were kind of had more questions at the end of this study as well, mostly focusing on more predictors of reoperation, reamputation to help guide our decision for treatments. Shoulder amputation, this was a study, a more recent one, basically finding very high postoperative complication rate. So I think, in my opinion, these patients are maybe better served with just these patients who need a shoulder amputation may be better served with just a more proximal below knee or above knee amputation. Finally, the prime knee amputation always is an option as well. So going straight to just removing the limb, either below or above knee. A couple of criteria, indications for certain patients that this will be good for. Obviously, the patients who are terminally ill, who have a non-functioning limb, or have basically arterial disease that cannot be reconstructed. These are the patients that you would want to consider doing this. And you shouldn't consider this a failure. These Kantian studies from that 163-page consensus basically said that, you should not consider a failure, but really it's just another option to really help the patient get on with their life and really have a quicker rehabilitation, wound healing, whether that's in bed or even with a prosthetic. Comorbidities all come into play with these sick patients. When doing limb salvage, you always want to consider them as a whole. All these patients have renal failure, or a lot of these diabetes, age greater than 60 years old, coronary artery disease, dementia. These are all risk factors for poor prognosis and poor rehabilitation after their amputation. And the more of these factors the patients have, the greater risk that you're going to have with dehiscence or failure of amputation. And I think these are just all factors that you want to keep in mind when you're assessing the patient as a whole and determining which level of amputation you want to be performing. This is finally one of the last studies I was looking at that just came out recently that I think was very helpful in terms of looking forward in terms of looking at more factors and how we can make a better decision for the patient. And functional ambulatory status, I think, is key when determining a level of amputation. And Armstrong and colleagues out of USC did the study with a group involving physical therapy and this limb salvage team that assessed the patient as a whole and really came up with 4 grades of ambulatory status, and kind of throwing this into the mix when determining the proper level of amputation. So basically, they gave a few examples. So their functional score basically was 0 to 4. The lower the number, meaning they're able to ambulate better. The higher the number means they're poorly ambulatory. So they gave an example like this. This patient comes in with this type of infection. He's a 55-year-old diabetic with an active job. He ambulates very well. He has a functional score of 0. And they're saying that, or their recommendation was based on the extent of the disease and the extent of rehab and limb salvage time required for this infection, that you can actually you may want to consider below knee amputation, which would give the patient quicker rehab. They'll be able to ambulate on a prosthetic instead of going through this long process of limb salvage, wound care, reconstructing the foot. And so I thought that was interesting. Second case on the right, a little bit different. You have a 65-year-old, more sick patient, so diabetes, peripheral vascular disease, end-stage renal, and dialysis. And they have a BK on the other side, and on this side now they have this gangrenous toe. And they're basically saying that because this patient already has a loss of limb on the other side, they really depend on this limb for transfers. They have a functional score of 2, so they were saying that you really want to consider limb salvage for this patient so that you prevent them from being bedbound after, rather than just going straight to BK or AKA. They'll end up losing both, have no limbs to ambulate on. My conclusions, basically, yeah, I think the ultimate goal of any amputation, you want a one and done. None of us want to be whittling away at the foot. It's not good for us, not good for the patient. And so I think I kind of left this study, doing this presentation with more questions. I think we still haven't found the right answer. I don't think we still are able to predict what level may or may not heal. But there's tools out there, and I think all those I touched on in this lecture. I think also really realizing the team aspect of limb salvage with the foot and ankle surgeon, vascular surgeon, physical therapist, as well as a patient support team, their family, whatever social status, social help that you can get, the more the better. Proper patient education, I think really getting the patient involved and informed in the process at the risks and benefits of how you end up at your decision for the level of amputation, letting them be involved in determining what's best for them and giving them the right information to help make them an educated decision. And end-stage renal is a major risk factor. I think something that keeps coming up, and there might be more than one good option. So I think for all of us, it's not always super clear cut. There's a lot of directions limb salvage patients can go, and we just want to be able to take all the information that we can to make the best decision. Future research, being able to educate the patient better of what will or will not work, giving them more information, whether that's more vascular studies, other studies to predict outcomes, and really looking at a classification system or risk scoring system to help guide us as foot and ankle surgeons to determine the level of amputation would be extremely useful. And that's all. Thank you very much.